Good morning, everyone. Welcome to today's session on gastrointestinal tract, respiratory, and neuromuscular junction pharmacology. My name is Dr. Fahmy. Over the next hour or so, we're going to embark on a fascinating journey through three critical systems in the body and explore how we can pharmacologically intervene to treat major diseases. We'll start in the gut, move to the lungs, and finally examine the communication point between nerves and muscles. This integrated view is crucial because while these systems seem separate, the pharmacological principles connecting them are powerful. Let's get started. To give you a clear roadmap, today's lecture is divided into three distinct parts. First, the gut, where we'll focus on taming acid and healing ulcers. Second, the lungs, where we'll discuss easing breathing in conditions like asthma. And third, the nerves, specifically controlling muscles at the neuromuscular junction, which is vital for surgical procedures. Think of this as a tour of three different battlefields in the body, and we'll be learning about the key drugs that serve as our strategic weapons on each front. We begin in the gastrointestinal tract. The stomach is not just a passive bag for food. It's a dynamic, acidic environment where a constant battle rages. Our focus for this section will be on peptic ulcer disease. An ulcer is essentially a wound, and understanding the pharmacology here means understanding how to tip the balance in this battle back in favor of healing and protection. So, let's dive into the stomach's battlefield. So, what exactly is a peptic ulcer? Simply put, it's an open sore or wound in the lining of either the stomach or the duodenum. The key to understanding its development is thinking about an imbalance of power. On one side, we have the body's defensive forces, a protective mucus layer, bicarbonate to neutralize acid locally, and good blood flow to promote healing. On the other side are the aggressive forces, primarily hydrochloric acid and the enzyme pepsin, which can digest protein, including the stomach's own lining. An ulcer forms when these aggressive forces overwhelm the defensive ones. Our drugs aim to either weaken the attack or bolster the defenses. To reduce acid, we need to know how it's made. Meet the parietal cell, the stomach's dedicated acid factory. It doesn't just pump acid randomly. It's carefully regulated. This cell has three primary keys that can unlock or stimulate acid production. Key 1 is acetylcholine, acting on the M3 receptor. Key 2 is the hormone gastrin, acting on the CCK2 receptor. Key 3 is histamine, which binds to the H2 receptor. When any of these keys are turned, they all converge on a final, common pathway, activating the proton pump or hydrogen ion or potassium ion ADPase. This pump is the final step that actually secretes acid into the stomach lumen. Blocking any of these keys or the pump itself is our therapeutic strategy. Building on that, our drug strategy is straightforward. Block the signals. We have strategic targets. Looking at the same parietal cell, we can place a pharmacological stop sign on different components. We can block the H2 receptor, we can block the M3 receptor, or most powerfully, we can block the final common pathway, the proton pump itself. The choice of which target to block depends on the clinical situation, how severe the acid problem is, how quickly we need relief, and for how long we need control. Our first major drug class is the H2 receptor antagonists, commonly called H2 blockers. Examples you'll frequently encounter are cimetidine, ranitidine, and famotidine. Their mechanism is exactly as the name suggests. They competitively block the histamine H2 receptor on the parietal cell. When histamine can't bind, one of the major stimuli for acid secretion is turned off. A key clinical fact to remember is that H2 blockers are particularly effective at suppressing nocturnal acid secretion. This made them historically very useful for nighttime heartburn and ulcer healing before we had more potent options. Let's look closer at H2 blockers. Their main uses include treating GERD, aiding ulcer healing, and preventing ulcers in patients who need to take NSAIDs long-term. They are generally well tolerated, but we must watch for specific adverse effects. The most important point involves cimetidine, the prototype. It inhibits the hepatic CYP450 enzyme system, which means it can cause significant drug interactions, increasing the levels of other medications like warfarin or phenytoin. Other H2 blockers have much less of this effect. Also, particularly in the elderly, they can cross the blood-brain barrier and cause CNS effects like confusion or dizziness. Now, let's talk about the heavy artillery. Proton pump inhibitors, or PPIs, often called the acid blockers. Examples are omeprazole, pantoprazole, and lansoprazole. Their mechanism is different and more powerful. They irreversibly inhibit the hydrogen ion/potassium ion ADPase proton pump itself. Since this is the final step, blocking it stops acid secretion regardless of which initial key was turned. This makes PPIs the most potent acid suppressors we have available. They don't just reduce acid, they can virtually shut down its production for 24 hours or more with a single dose. With great power comes the need for careful use. PPIs are indicated for severe GERD, for eradicating H. pylori as part of combination therapy, and for conditions of extreme acid overproduction like Zollinger-Ellison syndrome. Pharmacokinetically, they are prodrugs. They need to be activated in the highly acidic environment of the parietal cell's secretory canaliculus. Therefore, they should be taken 30 to 60 minutes before a meal, typically breakfast, when the proton pumps are active. Don't combine them with antacids right away, as antacids can raise stomach pH and interfere with activation. For adverse effects, long-term use is associated with potential B12 deficiency due to poor absorption, an increased risk of bone fractures, possibly from reduced calcium absorption, and a small increased risk of certain infections like pneumonia and C. diff colitis. For many duodenal and some gastric ulcers, acid suppression alone isn't enough. We must address a common root cause, the bacterium Helicobacter pylori. Eradicating this bug is crucial for a true cure. The standard approach is triple therapy. This involves combining a PPI to create a less hostile environment for healing, with 2 antibiotics, typically amoxicillin and clarithromycin. This combination attacks the bacteria from different angles. It's critical to understand that this regimen is for a cure, not just symptom relief. Without eradicating H. pylori, ulcers are very likely to recur. Beyond the main acid-reducing players, we have a supporting cast of other useful drugs. Antacids like magnesium hydroxide or aluminum hydroxide provide quick, symptomatic relief by simple chemical neutralization of existing acid. Misoprostol is a synthetic prostaglandin E1 analog. It protects the gastric mucosa by promoting mucus and bicarbonate secretion and maintaining blood flow. Its major warning: it is a powerful uterotonic and absolutely contraindicated in pregnancy as it causes abortion. Finally, sucralfate is a unique agent. It's not absorbed. Instead, it forms a viscous, protective physical barrier that coats the ulcer, shielding it from acid and pepsin. Let's summarize the gut. Taming stomach acid relies on 2 main classes: H2 blockers, which are good for moderate issues, especially nocturnal symptoms, and PPIs, which are the most powerful, are reserved for severe or persistent conditions like erosive esophagitis. Remember, if H. pylori is present, acid suppression must be combined with antibiotic combo therapy for a durable cure. This dual approach of reducing aggression and eliminating the trigger is the cornerstone of modern ulcer management. We now move from the gut to the lungs for Part 2, Respiratory Pharmacology. Our focus here is the fight for breath, primarily in asthma and COPD, chronic obstructive pulmonary disease. These are obstructive lung diseases where airflow is limited, but their underlying causes and precise treatments differ. Our goal is to understand the drug arsenal that helps ease this critical struggle to breathe. To treat asthma effectively, we must understand what happens during an attack. It's more than just a feeling of tightness. It's a pathophysiological triple threat inside the airways. First, bronchoconstriction. The smooth muscles surrounding the airways tighten, narrowing the passage. Second, inflammation. The airway walls swell due to an immune response, further reducing the diameter. Third, hypersecretion. Mucus-producing glands go into overdrive, producing thick plugs that can physically block the smaller airways. Successful treatment must address one or more of these three components. Our drug arsenal for asthma logically falls into two main strategic categories. First, we have relievers or rescue medications. These are quick-acting drugs, primarily bronchodilators, used to reverse acute symptoms during an asthma attack. Second, we have controllers or preventers. These are used daily, long-term to reduce the underlying inflammation and hyperreactivity of the airways, preventing attacks from happening in the first place. Confusing these two categories, using a reliever as a sole controller, for example, is a common and dangerous mistake in management. Let's detail the relievers, the bronchodilators. The number one rescue inhaler worldwide is a short-acting beta-2 agonist, SABA, like salbutamol, albuterol. It relaxes airway, smooth muscle in minutes. Next, anticholinergics like ipratropium block the constricting signals from the vagus nerve. They are particularly key in COPD. Finally, methylxanthines like theophylline are older oral drugs. They have a bronchodilator and some anti-inflammatory effect, but their use is limited by a very narrow therapeutic window, meaning the difference between a helpful dose and a toxic one is small, leading to risks like seizures and arrhythmias. Focusing on the most important relievers, beta-2 agonists. Their mechanism of action is classic. They activate beta-2 adrenergic receptors on airway, smooth muscle, which increases intracellular CMP, leading to relaxation and bronchodilation. We have two types, short-acting SABA, like salbutamol and terbutaline, for acute attacks, and long-acting LABA, like salmeterol and formoterol, which provide 12-hour relief for maintenance. A critical safety rule: LABAs should never be used as monotherapy for asthma. They must always be combined with an inhaled corticosteroid because using a LABA alone has been associated with an increased risk of severe asthma-related death. Now, the controllers, drugs that treat the root inflammatory cause. The number one, first-line controller for persistent asthma is an inhaled corticosteroid. Examples: beclomethasone, budesonide. They potently reduce airway inflammation with minimal systemic side effects when inhaled. Leukotriene receptor antagonists like montelukast are oral pills. They block inflammatory mediators called leukotrienes and are especially good for aspirin-induced asthma and allergic, atopic asthma. Mast cell stabilizers like cromoglicate prevent the release of inflammatory mediators from mast cells, but are less commonly used now as they are less potent than inhaled steroids. For severe, difficult-to-control cases, we have specialized biologic therapies. One example is omalizumab. This is a monoclonal antibody indicated for moderate to severe allergic asthma, where immunoglobulin E plays a key role. Its mechanism is elegant. It binds to circulating immunoglobulin E, preventing immunoglobulin E from attaching to mast cells and basophils. This stops the allergic cascade before it can even begin. It's a subcutaneous injection given every 2 to 4 weeks and represents a move towards highly targeted, immunologically based therapy. Asthma management is not one-size-fits-all. It follows a stepwise approach. For mild intermittent asthma, a SABA alone, as needed, is sufficient. Once asthma becomes persistent, we add a low-dose inhaled corticosteroid as the first-line controller. If control is not achieved, we step up. For moderate to severe persistent asthma, we can add a LABA in a combination inhaler with the steroid, add an LTRA like montelukast, or increase the dose of the inhaled steroid. The goal is to use the least amount of medication to maintain control. To recap respiratory pharmacology, first, relievers equals bronchodilators. SABAs are the first-line rescue for acute asthma attacks. Second, controllers equals anti-inflammatories. Inhaled steroids are the first-line controller for persistent asthma. And third, remember that COPD management relies heavily on different agents. Anticholinergics like tiotropium and LABAs are cornerstone therapies, while inhaled steroids are added in more severe cases or for frequent exacerbations. The strategy is tailored to the specific disease. We now arrive at our final part, pharmacology of the neuromuscular junction. This is the critical synapse, where nerves communicate with skeletal muscles to trigger movement. Our focus here is practical. How can we control this communication for surgery? We will learn about drugs that can temporarily paralyze muscles, which is absolutely essential for safe and effective modern surgical procedures. Let's refresh the physiology. At the NMJ, a nerve signal causes vesicles to release the neurotransmitter acetylcholine, ACH, into the synaptic cleft. Acetylcholine diffuses across and binds to nicotinic acetylcholine receptors on the muscle membrane. This binding opens ion channels, causing depolarization and ultimately muscle contraction. To stop the signal, the enzyme acetylcholinesterase rapidly breaks down acetylcholine in the cleft. It's a beautifully precise on and off system. Our drugs will either mimic, block, or preserve this natural process. Why would we ever want to block this essential function? The answer is for controlled, profound muscle relaxation. In surgery, this allows for several critical things. It makes endotracheal intubation much easier and safer by relaxing the vocal cords and jaw. It provides optimal surgical access to the abdomen or chest by preventing involuntary muscle movement. And it allows the anesthesiologist to use lower doses of general anesthetic agents. In short, NMJ blockers are a fundamental component of modern balanced general anesthesia. There are two fundamental pharmacological strategies to block the NMJ, leading to two classes of drugs. The first is non-depolarizing blockers. Think of these as competitive antagonists. They physically plug the receptor, preventing acetylcholine from binding, so the muscle never gets the signal to contract. The second strategy is depolarizing blockers. These are actually agonists. They mimic acetylcholine so well that they bind to the receptor and cause an initial depolarization, seen as muscle fasciculations, but then they stay bound, keeping the receptor in a perpetually depolarized and inactive state, leading to paralysis. Two paths to the same endpoint, relaxation. Let's explore non-depolarizing blockers first. They are competitive, reversible antagonists at the nicotinic acetylcholine receptor. Examples include vecuronium, rocuronium, and atracurium. Because they compete with acetylcholine, their effect can be overcome if we increase the concentration of acetylcholine in the synapse. This leads to a major clinical advantage. They have an antidote. At the end of surgery, we can administer an acetylcholinesterase inhibitor like neostigmine. By preventing acetylcholine breakdown, we flood the synapse with acetylcholine, which outcompetes the blocker and restores muscle function. The classic and primary depolarizing blocker is succinylcholine, also called succinylcholine. It's unique. It's essentially two acetylcholine molecules linked together. It acts as an agonist, causing an initial, brief muscle contraction or fasciculations before inducing paralysis. Its key clinical features are its very fast onset, about 30 to 60 seconds, and very short duration, 5 to 10 minutes. It's metabolized not at the synapse, but in the plasma by an enzyme called pseudocholinesterase. A crucial point, it has no specific antidote. You must wait for it to be metabolized. Here's a direct comparison. Mechanism. Non-depolarizers are competitive antagonists. Succinylcholine is an agonist. Onset/duration. Non-depolarizers like vecuronium have a slower onset and longer duration, 30+ minutes. Succinylcholine is ultra-fast and short-acting. Antidote. Non-depolarizers have 1, neostigmine. Succinylcholine does not. Example, vecuronium versus succinylcholine. This table helps you choose. Use succinylcholine when you need speed for a quick procedure or rapid intubation. Use a non-depolarizer for longer, more controlled surgical relaxation. Clinical vigilance is key with these powerful drugs. For succinylcholine, be aware of the dangerous side effects. It can cause a dramatic release of potassium, leading to life-threatening hyperkalemia, especially in patients with burns, major trauma, or spinal cord injury. It's also a known trigger for malignant hyperthermia, a rare but fatal hypermetabolic crisis. 4 non-depolarizing blockers. The main pearl is that you must ensure adequate reversal at the end of surgery to prevent post-operative respiratory weakness. We monitor the degree of blockade objectively using a peripheral nerve stimulator. To understand the NMJ better, let's look at a disease where it fails, myasthenia gravis. This is an autoimmune disorder where the body produces antibodies that destroy or block nicotinic acetylcholine receptors on the muscle side. The symptom is muscle weakness and fatigue that improve with use and improves with rest. Pharmacologically, the treatment logic is the opposite of what we do for surgery. Here, we want to enhance transmission. We use acetylcholinesterase inhibitors like pyridostigmine. By inhibiting acetylcholine, we increase the amount and duration of acetylcholine in the synapse, allowing it to stimulate the few remaining functional receptors repeatedly. Summarizing the NMJ, we have non-depolarizing blockers, competitive, reversible, with an antidote for controlled, longer paralysis. We have the depolarizing blocker, succinylcholine, an agonist, fast and short, no antidote, for rapid sequence intubation. Their primary use is to provide surgical muscle relaxation. And in the disease myasthenia gravis, we flip the script and use acetylcholine inhibitors to enhance NMJ transmission and overcome the receptor deficiency. Let's step back and see the bigger picture. Do you see the pharmacological links across these systems? Anticholinergics. We use them in the gut to reduce acid via M3 blockade, and in the lungs to cause bronchodilation. The fundamental concept of receptor agonists and antagonists is universal, applied to H2 receptors, beta-2 receptors, and nicotinic receptors. Steroids are powerful anti-inflammatories in both respiratory disease and many other systemic conditions like autoimmune disorders. Can you think of other connections? Perhaps how the autonomic nervous system drugs appear in all 3 systems. This interconnectedness is the beauty of pharmacology. Let's apply our knowledge. Case 1. A 45-year-old executive with severe GERD who also takes daily NSAIDs for chronic back pain. What is the best drug class for him? The answer is a proton pump inhibitor, PPI. Why? First, for his severe GERD, PPIs provide the most potent and reliable acid suppression. Second, and crucially, NSAIDs inhibit protective prostaglandins, increasing ulcer risk. A PPI is the most effective agent to prevent NSAID-induced ulcers while treating his existing GERD. An H2 blocker might not be potent enough for this dual challenge. Case 2. A 16-year-old presents to the ER with an acute asthma attack, short of breath, wheezing. What is the first drug you should administer? The answer is a short-acting beta-2 agonist, SABA, specifically salbutamol via inhaler or nebulizer. Why? In an acute attack, the immediate threat is life-threatening bronchoconstriction. SABAs are the fastest-acting bronchodilators, providing relief within minutes. They're the cornerstone of acute rescue therapy. After stabilizing the patient, you would then assess the need for controllers like steroids. Case 3. A patient requires rapid sequence intubation for emergency surgery following trauma. Which muscle relaxant is ideal? The answer is succinylcholine. Why? In this scenario, securing the airway quickly is paramount to prevent aspiration and ensure oxygenation. Succinylcholine's ultra-fast onset, within 1 minute, makes it the agent of choice for rapid sequence induction. Its short duration is also acceptable for many emergency procedures. The slower onset non-depolarizers would not be appropriate here. Let's consolidate with key drug lists. Forget, you must know, the PPIs, omeprazole and pantoprazole. The H2 blocker, famotidine. Remember, cimetidine has the interactions, but famotidine is a common, cleaner alternative. And the triple therapy combo for H. pylori, PPI plus amoxicillin plus clarithromycin. Commit these names and their classes to memory. For respiratory drugs, Know your relievers. Salbutamol, the quintessential SABA, and ipratropium, the anticholinergic. For controllers, know inhaled corticosteroids, example, budesonide, as the first line, and montelukast as the oral leukotriene antagonist. These are the workhorses of asthma and COPD management. For the NMJ, know the prototype non-depolarizing blocker, vecuronium. The depolarizing blocker, succinylcholine. Its antidote for non-depolarizers, neostigmine. And the treatment for myasthenia gravis, pyridostigmine. This covers the core agents for paralysis and its reversal. Reviewing mechanisms of action helps categorize drugs. Receptor blockers, H2 blockers, famotidine, anticholinergics, ipratropium, non-depolarizing blockers, vecuronium. Enzyme inhibitors, PPIs, inhibit hydrogen ion/potassium ion ADPase, acetylcholinesterase inhibitors, neostigmine. Receptor agonists, beta-2 agonists, salbutamol, depolarizing blockers, succinylcholine. Classifying drugs by mechanism simplifies pharmacology. Always be vigilant for adverse effects. For PPIs, think long-term risks, B12 deficiency, fractures, infections. For beta-2 agonists, expect tachycardia, tremor, and hypokalemia. For succinylcholine, the big one is dangerous hyperkalemia. For cimetidine, remember its CYP 450 inhibition leading to drug interactions. Associating a key side effect with each major drug is a vital safety practice. Knowing when not to use a drug is as important as knowing when to use it. Misoprostol has an absolute contraindication, pregnancy, due to its abortifacient effect. LABAs for asthma, never use as monotherapy. Always combine with an inhaled steroid. Succinylcholine, major caution in patients with burns, major trauma, or spinal cord injury, especially 24 hours to several months after the injury, due to the risk of catastrophic hyperkalemia. These cases and lists illustrate fundamental principles in action. Selectivity. Salbutamol selectively targets beta-2 receptors over beta-1 to minimize cardiac side effects. Therapeutic window. Theophylline has a narrow one, requiring careful monitoring. Prodrugs. PPIs are inactive until activated in the acidic parietal cell. Competitive antagonism. Famotidine at H2 receptors, vecuronium at nicotinic acetylcholine receptors. These principles are the bedrock of rational drug use. When you encounter any new drug, use this pharmacologist checklist. First, ask, what is its class and mechanism of action? Second, what are its main clinical uses? Third, what are its key side effects and toxicities? And fourth, are there any major contraindications or drug interactions? Applying this simple four-step framework will help you master any drug, not just the ones we covered today. Finally, a glimpse into the future. In the gastrointestinal tract, research aims for safer, longer-lasting acid suppressants with fewer long-term risks. In respiratory, the frontier is biologics like omalizumab, highly targeted antibodies for severe asthma subtypes. In NMJ, a major advance is the development of new, specific reversal agents for non-depolarizing blockers, like Sugemadex, which can rapidly reverse paralysis by encapsulating the drug. Pharmacology is a dynamic field, constantly evolving to provide safer and more effective therapies. And that brings us to the end of our journey through gastrointestinal tract, respiratory, and NMJ pharmacology. Thank you for your attention.